It's great to see so many people on the call. Thank you for attending, and I hope you find this interesting. We're going to talk today about a new way that we've developed to publish and release our A&E statistics. If you move to the next slide for me, Eva, thank you. I'll start just by introducing who we are and what we do and a bit of background to the development. So my name's Emma McNair and I'm an information consultant in Public Health Scotland. I'll then pass over to Kathy, who's one of our principal analysts, and she'll tell you a bit more about the A&E statistics that we release and who uses them and the kinds of things they use them for. And finally, probably the bit that's of particular interest to this sort of community, the technical side of it. So Ava, one of our senior analysts, will tell you a bit more about the technical development that we've done for the output that we've developed. I think there's time for questions at the end. If there's anything really burning during, I don't mind being interrupted if it's a point of clarification, but there will be time for questions at the end as well. So thanks, Eva. So we are Public Health Scotland. I think there may be some colleagues from PHS on the call, and certainly some of you will be partners that work with us. But for anyone who's not aware, we are Scotland's national public health body. So we lead and support work across Scotland to prevent disease, prolong healthy life, and promote health and well-being. So a challenging and quite a broad remit. Public Health Scotland's quite a new organisation. It was brought together in 2020 from a number of legacy organisations. Launched on the 1st of April, so just as COVID was kicking off. So understandably a challenging time to launch a public health body. And probably that's where a lot of people kind of first heard about Public Health Scotland, through the COVID statistics and vaccination programmes and so on. A key part of what we do in Public Health Scotland is around data and information. We need really good, robust data for evidence to inform policy and for monitoring and so on, and evaluation. So that's the side of the business that myself and Kathy and Eva work in. We sit in an arm of the organisation that is focused on information delivery. So that's about reporting statistics and providing analysis and data to a range of stakeholders. And we focus on unscheduled care. So unscheduled care covers A&E, we're going to talk about today, but also covers wider system of unscheduled care. So things like primary care, out of hours services. And we also handle things like ambulance service statistics and NHS 24 statistics as well. So it's a complicated system by its very nature, the kind of unscheduled nature of how people access and use those services. So the next slide, thanks. So the project we're going to talk about today is a project we've undertaken to really think about how we publish A&E statistics. We were taking stock last summer to look at the releases that we had. So we had standalone weekly, monthly and annual publications. So it was separate kind of web pages on the PHS website. And a lot of really good work had already been done, thanks to Ava and other members of the team, to automate the processing behind those publications and make it as efficient and streamlined as possible to release them. A lot of that's because of the very tight turnarounds, particularly for the weekly release. There's some of the challenges around that kind of format of release was that we had these standalone publications with similar but slightly different content, and there were good reasons for those differences, but it meant that for users accessing them, it's potentially a bit confusing to navigate and understand the differences between figures in different places, and to understand which figure to use for different purposes. Also, the PHS website is still relatively new and evolving, so the searchability and navigation of that website and the kind of posting of information is still some way to go, I think it's fair to say. And so it's not that easy to direct people to the kind of standalone releases as they were. We had quite a high volume of bespoke requests as well for information that we didn't routinely release. We had quite high volumes of people asking for FOIs or for particular cuts of data or particular bits of analysis. So last summer when we were taking stock, we kind of thought about where do we want to get to, what do we want to achieve? And key things we felt we needed was to have a single home for A&E stats. So somewhere that we can direct people to that's easy to find, it's easy to use, they can find what they need and hopefully largely self-serve from that one place. We definitely didn't want to lose a lot of that good work that's been done to automate the processing and the production of the stats. So we wanted to kind of build upon what had already been done there. We were keen to get to a point of having clear and consistent labeling across all of the outputs and to have metadata that covered everything in one place, and keen to present the information in such a way that it kind of engaged users, allowed them to interact, and was easy for them to sort of identify the key aspects or the key points of the data and help them understand what they were seeing. We didn't want to come up with a solution that we were then very fixed in how we could release things. So we wanted that kind of flexibility to be able to add on extra bits and develop it and broaden it as we go on. And lastly, we were keen to make more use of the open data. So we've had for some time some open data for A&E, but we wanted to expand the offering there to allow others to use it more, and also to look at ways that we could use it in different ways internally. So as I say, that sort of thinking started last summer, and we've worked through, and I'd say we're quite far into achieving most of those aims now. So we'll go on in more detail to talk about what the sort of things that we've produced, but we're hoping next month to fully kind of switch to that. So just a note to say that this is all in parallel to much broader sort of strategic work in Public Health Scotland to look at the way that we publish information, statistical information. So there's a variety of ways that's been done in the past. So it can be as PDF reports. There's more and more kind of dashboard formats that have been happening over the last few years. There can be things like lots of suites of Excel tables and that kind of thing. I think it's fair to say there's probably never going to be a one-size-fits-all for all A&E, for all PHS statistical outputs. But what we've done is try and develop a sort of an option that could be used. And we've also, in parallel to this work, been looking at the internal monitoring information we produce and provide to key stakeholders such as the government and NHS boards, partly with a view to consider whether some of that could be published rather than just being used internally, again, to make it more available to other types of users. For the next slide. Thanks. So just briefly, the way we approached the work was from the start, we kind of acknowledged that we wouldn't be able to achieve all those aims by ourselves as an analytical team. So we worked with a variety of teams across Public Health Scotland. We were keen to view it as very much a proof of concept, so giving us a bit more space to innovate, try something new, potentially take bits of it forward for other things, and potentially not, offer it out to other teams and other people to use if they wanted to as well. So it kind of gave us a bit of flexibility to how we wanted to develop it. It was an agile development, so we didn't have very fixed time scales or milestones. We were flexible to that, and we kind of phased the release and the development with iterations and stakeholder feedback as we went along. And again, we had the luxury of being able to do that, partly because we kept the legacy outputs going in parallel for a time. Some of the key drivers, just to mention that we kind of had to think about, were around official statistics requirements. Because the A&E stats are national statistics, there's a number of really important things we had to build into the development to adhere to the code for official statistics. And another key thing we wanted to address was some of the accessibility. We wanted to try and make sure that not only was the information easy and user-friendly to look at and clear, sort of understandable labeling and so on, but also in terms of technically for software for people with vision impairment, for example, to try and improve some of that accessibility as well, because we're aware that some of the other dashboards PHS has produced are not great in that respect. So we were trying to look at ways we could improve that too. So I'm going to pass over to Kathy now, who's going to tell us a bit more about A&E stats.
Okay, thanks, Emma. Sorry. Okay, so as Emma said, we publish data monthly and weekly, and this slide kind of goes into a bit more detail as to what we publish. And this is what we have on our public-facing website as opposed to our internal sort of management information. So what we have now currently published on our website is the overall number of A&E attendances. We also have information on how long people spend in A&E. That looks at the time they arrive at A&E and when they're then discharged from an A&E department. We've also got data on who attends A&E, and that's mainly demographic information, looking at sex, looking at age groups, and looking at deprivation. And there's some kind of key findings we have there around that people living in the most deprived areas are more likely to attend A&E, and similarly other demographics as well. We also have information on when people attend A&E, so that's like by day of the week and time of the day. We also split it into sort of the in-hours period and the out-of-hours period, and that's in-hours period is kind of defined when the general practices are open, and the out-of-hours period is like weekends and evenings. And you often find that Monday is the busiest day of the week when people attend A&E. So next Tuesday, we're going to be updating the website to include some additional information. So the two initial bits we'll be looking into is routes into A&E departments. So that's how people end up at A&E. So looking at, for example, people that can self-present to A&E or end up going to A&E after a call to NHS 24. I think it's around half of people currently self-present at A&E departments. We'll also be looking at what happens when people attend A&E. Are they discharged home or are they admitted to hospital? Around, I think, 70% of people are currently discharged home following A&E attendances. And we'll also be looking at publishing data on people with multiple attendances. So this will be looking at people that in any given year attend. Do they attend once a year, twice a year, 3 times a year, 4 times a year, or 5 times and more? And we'll be breaking down that information by age group and demographics to see if there's any factors that influence whether someone's a multiple attendance or not. Sorry, Eva, do you want to? Thanks. In addition to the kind of standalone A&E statistics we produce, we also link A&E data to other data sources, and Emma kind of mentioned at the start of the wider unscheduled care system. So we actually have a data data mart that we call it that links A&E data to Scottish Ambulance Service data, NHS 24 data, emergency admissions, and primary care out of hours data. And that kind of provides a sort of a pathways type analysis looking at patient journeys. So at the moment, we don't publish any of that, though there is data on pathways contained in some of our internal management information. Maybe the next slide, Eva. So who uses A&E data at the moment? Well, there's a variety of data, but the slide just kind of demonstrates the main users of the data. So probably the most, the highest profile is the Scottish Government, and policymakers make extensive use of both our published data and our internal management information. The media, particularly around the sort of weekly emergency department publication, we get quite a lot of interest, and you'll probably seen it in the news that most weeks tends to be on the sort of one of the main items in the Scottish news, though it hasn't been latterly, which is good for us. We also get a lot of interest from researchers and universities who like to use A&E data in research studies, and the general public as well. We get queries. I think the general public may be more so coming from it from a kind of patient satisfaction point of view. We get queries from the voluntary sector as well as NHS boards and health and social care partnerships. Data requests come in a range of forms, whether it's an email just specifying they would like data, or more formally, we get a lot of freedom of information requests. We also get parliamentary questions, and PHS have got strict protocols as to how we answer these FOIs and PQs as they're called, and they are published, and they're made. It's already transparent what our responses are to those. Okay, next slide. So the next couple of slides are just kind of examples of how the data is used, or some uses of the data. And I suppose the main and high profile use of the data is to monitor the Scottish Government standard, which is which I have on the slide there. So it's 95% of patients to wait no longer than 4 hours from arrival to admission, discharge, or transfer for A&E treatment. Now that standard has probably not been met for a couple of years now, and we're around about, if you look at our most recent publication, it's kind of been around 65%. So it's quite a way below the standard, but that's similar to the other parts of the UK as well, are all in a similar position. So the last slide that I'm going to cover is just looking at some uses of the some research studies that have included A&E data. So there was I mean, this is just a snapshot, because there's a lot more. So there's one that was looking at the patterns of use of unscheduled care by general practices, looking at variation across different general practices in terms of how people access unscheduled care, including A&E. There's also the out-of-hospital cardiac arrest project, and this was looking at the impact of interventions to help with outcomes of people that have cardiac arrest. And I'm sure you've seen a lot more defibrillators in public places. So the A&E data has been used to sort of measure the impact of any interventions there. There is also a national diabetes data mart, and that looks at a cohort of people who are with type 1 and type 2 diabetes, and looks at how they access various unscheduled care services, including A&E. There was a SIV2 study looking at the investigation of vaccine effectiveness, again looking at A&E data as one of their measures. And more recently, there was a study looking at there was a lot of children particularly being admitted to hospital with very short lengths of stay, which made it felt these were probably inappropriate admissions. So that A&E data was used for that study to help inform priorities for future interventions for children's referrals into hospital. So I suppose my part of the presentation is just to sort of say the data is used widely and a variety of purposes, and it's a kind of very high profile data set within PHS. So I'll now pass on to Eva, who's going to kind of delve into the more technical side of the publication. Is that okay? Thanks.
Hi, yeah. I'll give a quick overview of the new format and try to talk you through a little bit in how it works in the background. Okay, can everyone see this? Okay. So this is how the new format of our publication looks like. We start with a sort of overview of what A&E is and trying to explain what the differences are between the different A&E departments, considering different parts of our publication focus on different sections of that. So we've tried to make clear what applies to what section of the publications. Then we have our main points, which we used to have in our summaries, with just the high level figures for Scotland by month, which is for all A&E sites, and by week, which is just for the emergency departments. So those get updated monthly and weekly. And then we have the interactive charts, which is where we used our Shiny. When we start this process, the publications team suggested us to maybe make smaller dashboards that can be embedded on the website instead of making bigger dashboards that would maybe be more common. The reason they suggested it is to make the navigation easier, so the navigation largely stays on the website as it is, and also make the information more searchable, because most of the text will be on the website as it is, so it should hopefully be easier to be found by search engines. So we made multiple smaller our Shiny dashboards, which are all embedded. The downside is that we have to make a couple of our Shiny dashboards, but the advantage is that they all are a bit simpler. So if you need to make changes, it's often a bit easier to figure out what needs to happen. And then the final thing I wanted to talk about is that currently we only have parts of the data running off the open data platform, but we're hoping in the near future to run everything from the open data platform, which would mean that we don't have to deploy the dashboards every week, but that they can just automatically pick up the data from the open data platform. Then aside from the dashboards, there's the normal data files and how to get to the open data, and also all the background information, metadata, glossary, and things all live on the one page. So users can find, or should be able to find, hopefully everything they want to know about A&E that we have on one website. So just to repeat, so all the navigation is being done on the PHS website, which should hopefully improve accessibility and searchability, and having some simpler or shiny dashboards embedded. We've had some issues with legends not working as we would like with embedding, but we found some workarounds for that. But in general, it seems to work pretty well. And like I mentioned, we have all we aim to move everything to open data, so all the dashboards should just automatically get all their data from the open data platform in the near future. Thank you for your time, and I think that's time for questions.
Hello, yeah, hi Surya. If you have a question, if you wouldn't mind raising your hand, and then we will we'll come to you. So Surya, did you have a question?
Yes, I did. I did raise my hand. I was just wondering how the format is. Yeah, I had a couple of questions actually. Well, the first one is for Kathy, because she said about what is it, self-presenting people at A&E and those who come through NHS 24. So are these routes kind of important in terms of analysis, like to know how they come through? Are we trying to reduce something, or?
I think, yes, I think part of a few years ago, there was a programme of work called the Redesign of Urgent Care, and it was trying to make sure people access the most appropriate services for them. And sometimes A&E isn't necessarily an appropriate place for a person to be, and that they'll turn up at A&E when maybe if they phoned up NHS 24, they could have, NHS 24 could have resolved that call. So that kind of information is useful for analysis purposes, because I think they want to monitor to see to maybe some reductions in those people self-presenting and going through other routes, if that makes sense. So yeah, that kind of information is certainly from a policy point of view is useful, and is what the Scottish Government are very keen to see as well.
Perfect. Thank you, Kathy. And the other one is for Ewan. You kind of mentioned the open data platform. So I think I saw the link very quickly. Is it the opendata.nhs.scot? Because there are multiple platforms that kind of gather and give you the open data information.
Yeah, it's the NHS open data link, yeah.
So everything that you kind of were working on will be on there, or you're just trying to load them?
Yeah, so we currently only have the monthly data on there, but in the near future, all the other ones should be appearing there as well.
Perfect. Thank you. And the last one is for Stephen. Will you be sharing the slides?
We haven't discussed that, but we will have a recording, so we can share the recording, and I can speak to the PHS team afterwards to see if we can have the slides as well.
Perfect. Thank you. That was really informative.
So I think Steve Black was next. Steve.
Hi. I was going to ask a technical question about the tools you're using to do the visualizations, but Catherine just brought up the issue of using the evidence that you're presenting to effectively make policy decisions, like, can we divert people away, get them to go somewhere else, get them to go to the appropriate place. But I'm wondering, given the experience in England of some of major issues about A&E. So they spent about 10 years where the primary policy was, let's try and divert as many people away from A&E as possible, which they couldn't find a way to achieve. So that's a problem. And secondly, we had plenty of good analytical evidence that said, even if they had achieved diversion, it wouldn't have improved performance. So I'm wondering in Scotland whether you have any concrete examples of where better use of the data has actually led to a change in policy or a change in what you're trying to do.
That's a difficult question to answer. There are some caveats with the data and quality issues that I should have flagged up as well. But I'm not sure. It's hard to get concrete examples. I don't know, Emma, if you want to come in.
I mean, there's been a lot of work in Scotland. There was a redesign of urgent care programme. There's various kind of policy programmes that are trying to crack this very nut, because it's not an easy one to fix. And like, I think the approach now is much more a sort of wider whole system view approach. It's, you divert people away from A&E, but that has impacts on other services as well. There's a whole range of new evolving services in the community and so in hospitals as well, actually kind of running alongside A&Es now. And this is what we're starting to do in Public Health Scotland, to kind of map all of that and look at how data's captured and what we can do nationally with that. So you're not really answering your question, Steve, but it's a very difficult one. I can't think of a sort of concrete example that really strongly demonstrates exactly how some data was used, but it is used routinely, but it's a very complicated picture with lots of different data being used, if that helps.
Could I just throw in, because there's two things that we knew more than a decade ago in England from looking at the performance data for A&E. One was there is no relationship between the number of people turning up at major A&Es and the performance. So that was clear in 2003 in England when we first started to gather some of the data. That's kind of an important observation, which should influence what people are trying to achieve in policy. But NHS England ignored it for the best part of a decade. The other thing that we know, and this was done, I think, as early as 2001 by the Audit Commission when they still existed, there's no relationship between staffing levels in A&E and performance. And that sounds like a pretty important thing to realize when you're doing things about, say, we're going to try and solve the problem of inadequate performance, because if staffing isn't the bottleneck, then you've got to put your effort somewhere else. So I just wonder whether or not any of that sort of thinking is going on in Scotland.
I think it has gone on in Scotland, and it's. I think there's too many other factors at the same time. I mean, when the redesign programme was introduced, it was the height of COVID, so it's hard to extrapolate out what caused what. But these are discussions that are been ongoing in Scotland as well, about staffing levels, about numbers coming. About the one thing is that we can't really crack is the acuity. So the kind of anecdotally, people are saying people are coming to A&E with higher acuity, but we can't demonstrate that with our data at the moment with any robustness. So
okay.
Sorry, Steve, I'm not answering your question, but you're asking legitimate.
It's an interesting one. I mean, on the acuity thing, I mean, there were several big studies done in about 5 years ago in England which couldn't find a big effect. It's not that they couldn't find the data; they couldn't find a big effect.
Yeah.
But it's one of the things that hospital doctors say. Well, this is the reason why things are worse. It's not our fault.
Yeah.
But actually, it's not an evidence-based statement. It's somebody trying to divert the blame.
Yeah, there's a lot of variation across the country as well. It could be proximity of A&E departments. I mean, there's a whole range of factors as to why people, it's.
Yeah. But I'll let other people ask questions on it.
Okay.
Thanks, Steve. So there's a couple of people with their hands up, but there's also a couple of questions in the chat. So Gerard Skillion is asking, when you get to the point of automating the extraction of data from your open data platform, will you stop publishing the files as CSV or Excel format? I'm not sure who would be best for that one.
I think we're planning to still publish the Excel and CSV as well. It's different users will use data in different ways, so we will try to provide for all those use cases basically.
Thank you. And then next with their hand up is Malcolm.
Hi, thank you. Yeah, and thank you to everybody. Brilliant presentation, thoroughly enjoyed it. And Steve, great questions as well. Mine's a little bit simpler and more direct. So you mentioned the use of smaller, more frequent, if you like, dashboards rather than a big composite dashboard. So what's the key driver behind that logic?
So the main reason to do it this way is what our publication team suggested, is that it's smaller dashboards, so all the navigation that the user will do, aside from maybe a drop down or whatever, is on our website. So it's hopefully easier to control for the users, considering some are shiny dashboards with a lot of tabs can be harder to navigate, certainly if you need to navigate into an iframe on a different website. It can get quite complex. So that's the way. That's why we did it in this way.
Okay, and have you had a chance for any feedback yet? I mean, it'd be interesting to see what people think of that new approach.
I think so far feedback has been quite positive. We're still trying to test more with people, but so far feedback has been quite positive. Yeah.
Brilliant. Thank you.
Thanks, Malcolm. There's another one in the chat from Lorna who's asking, are your dashboards embedded in your R Markdown script or R Shiny, and are you planning to put the code on GitHub?
R Shiny, they're just on R Shiny, not on Markdown. It is currently not on GitHub, but it is something we can consider.
Thank you. And then I think next with the hand up is Kate Lyon.
Thanks very much, and hi everyone. Thanks. Yeah, really enjoyed the presentation. Really interesting to see what's happening. A little follow on to the user feedback. Are you able to track through the website which of the most popular graphs, data sets, etc. people are interested in and are downloading?
I think our web team can. Sorry, Eva, do you?
Yeah, no, sir. Good.
Yeah, chip in after me if you've got more information. I think the web team can monitor the page views. So because of the way it's structured, you know, there's different bits on different pages. So I think they can tell us which pages are getting higher numbers of views. I'm not sure, Eva, I don't know if there's any way from the dashboard side that you can sort of tell interaction with that.
Not that we have set up currently. So that is work in progress, let's say.
Great, thank you.
And I think, Steve, are you back with another question?
Yes, I thought I'd ask this is a technical question about how you've implemented everything rather than what about the content. So if I look at interactive content that a lot of healthcare people have chosen to publish, that there seem to be 2 or 3 different ways they choose to do it. A lot of people do what you've done, which is you build a lot of interactive content using open source tools, which requires a lot of development time, I guess, but it's really cheap to deploy. But it's also quite common for people to use tools, commercial tools like Tableau or Power BI. They seem to be the 2 most popular, which are relatively cheap to develop in because they build in a lot of the features you want and interactivity is just there. But they're quite expensive to deploy. I wonder how you trade one of the development time versus the deployment cost when you're thinking about which tool to choose.
I would say with the development time for the R Shiny wasn't too bad because it's a fairly simple dashboard, some drop downs and a chart. We do use Tableau quite widely in the organization, but our publications team is not a fan of publishing in Tableau due to some accessibility issues that they've found in the past.
Oh, I'd be interested to know what they were. It's just
I can if you can send us an email, we can get you in touch with our publications team.
Yeah, and I think part of the work, this kind of proof of concept work was almost, you know, maybe what we've done can be a template for other teams to use. So it took a lot of time developing that structure and that layer and all that. So if others agree that works for the kind of outputs they're doing, they can adopt a lot of that. So we've some efficiencies there that we've kind of done a lot of preparation there that others can then adapt to other topics and other outputs.
So I think that is the last of the questions. I can't see any in the chat that haven't been answered yet, unless anybody else has anything they'd like to ask. Just last chance to get your questions in.
I think there's one further up about user engagement from Joseph Adams.
Oh, I might have missed that one. Oh yeah, sorry.
Yeah,
So yeah,
just
Joseph's
reading it.
asking, thank you very much. Could I ask how if and how users were involved in the change, and do you have any thoughts on the guidance from the analysis function?
So the first part of that, so we have regular engagement with kind of key stakeholders, so largely government and some NHS users as well. So we kind of had regular sessions with them talking about the plans and the vision of what we wanted to do, and then opportunities for them to comment on it as it developed. We've got a feedback function on the pages, so there's like a form that people can fill in, and there's contact details as well, so people can send us information. We did talk with our web and kind of marketing colleagues in Public Health Scotland about doing some broader engagement with public, for example. That hasn't happened yet. I think they've got kind of thinking about doing that for other topics as well. So we haven't done that yet, but I think we should to find out, what the kind of comments would be from that audience. Is there anything else, Kathy, about with media? We've got some specific kind of targeted feedback from media lined up as well, because they are high users of A&E stats. I think I have seen that civil service guidance before, and I think actually I think we did look at that during the development process as well. So but thank you for the reminder. We'll have another look and see if there's any other things in there that we should take into account.
Thank you. And what I've just found one other question that we hadn't got to, which is from Jose, who's asking about the deployment of PyScript, and with that development, will you be looking to change the way the dashboards are embedded?
I'm not aware of that, but we can have a look.
And then maybe the last question has just come in from Nathan. Would it be possible to see how many patients are referred onward to specialist pathways, for example, cancer pathways?
We can't really, unfortunately, we're not able to do that with our A&E data alone, but I know that we have linked data with, we did some work with A&E data, which we linked for Macmillan. So it's not something we routinely do, but I can find out what happened to that bit of work that was looking at A&E and cancer services. And I'll maybe email you, Stephen, if there was anything that was published.
Thank you. And we've just got one last question in from Steve, or hand up from Steve, sorry.
Well, yeah, sorry. Well, I thought you've got time. I might as well ask the last question.
May as well, yeah.
Is the basis for the A&E data you're doing patient level?
Yeah,
So,
the data's up. Yeah.
So have you tried linking, because this is something which we did do recently in England, the patient level A&E data on how long the patients wait to the mortality data for those patients, the extra death certificate driven mortality data?
Yeah, I mean that's we routinely link the A&E data to mortality data and what in our unscheduled care data mart. So we've not recently looked at that data, but it is something that we can do.
So you could look at the relationship between how long the patient waited and what
technically, technically
okay.
Yes, but you can understand that would be quite sensitive analysis, because there might be other reasons for the mortality, like age group or fact, the reason they were at A&E attendance. So it would just be quite sensitive to make that. Someone may have waited 12 hours and died, but you can't actually say that was the reason they died, if that makes sense. But it's certainly something we can look at.
Okay, but I don't know whether you're aware of it, but there was a publication based on about 2 years worth of patient level data.
Yeah, that's right. Yeah.
So that was a fairly influential publication.
Yeah, and I think that's been used to extrapolate things in Scotland. I think, as far as I know, I can't remember. It was published in one of the major journals, I think. Sorry,
it has.
Emergency Medical Journal last January. 2022. But the reason why I ask is because it would be really interesting to know whether or not the same pattern is observed in Scotland, and
we did look at that work and discuss it with government colleagues, and I think when you dug into some of the detail of how that analysis has been done, it would be difficult for us to replicate it in exactly the same way here. But there was some discussion, but as Kathy said, that kind of concluded that actually the kind of caveats around the outputs would make, I think it didn't progress. I suppose we didn't go ahead and do it at that stage, but there's potential there to do that kind of analysis, but it is quite complicated.
Very good.
Okay, well, thank you again to the team from Public Health Scotland for speaking to us today. Nadia, you've asked in the chat if when the recording will be available, so we'll hope to get the recording up by this time next week. So if you've missed the beginning of the session or you want to kind of recap and kind of go over it again, then that will be available for everybody. But if there aren't any questions, I'd just like to say thank you again to the team from Public Health Scotland and for all of you for joining us. And if you aren't a member, please do join the Data Lab community at community.thedatalab.com. Thank you.